This is the DocNation Podcast. We are a movement founded by doctors, for doctors, dedicated to empowering medical professionals to reclaim control over healthcare decisions and advocating for their fair share of the industry's resources. Please note, the views expressed are those of DocNation and not necessarily those of our guests or referenced health centers. Today we have a truly remarkable guest joining us, Dr. Michael DellaVecchia. If we were to list every accomplishment that he's achieved, we might need an extra episode. Dr. DellaVecchia is a physician, surgeon, researcher, professor, and innovator with expertise spanning ophthalmology, pathology, biomedical engineering, and even aerospace medicine. He's held leadership roles in multiple medical societies, advised NASA, worked on cutting-edge medical technologies, and has been at the forefront of healthcare policy advocacy. But beyond the titles and accolades, Dr. DellaVecchia is someone deeply committed to advancing patient care, medical education, and the future of physician leadership. He's a former president of the Philadelphia County Medical Society and has been instrumental in shaping resolutions on everything from contract transparency for physicians to public health initiatives. We're honored to have him with us today to share his insights on the evolving landscape of medicine, the challenges facing physicians, and what needs to change for the future of healthcare. Dr. DellaVecchia, welcome to the show.
Thank you. Happy to be on board.
So tell us about what are some of the things you're seeing right now within the healthcare landscape, and what are some things you're working on?
Well, within the healthcare landscape, it's very dynamic and it's going in a lot of different directions, as we all know as physicians. You have the medical legal aspect, which in the Pennsylvania area is really tragic and totally unremarkable. You have the reimbursement aspect, which is related to the federal government, but also the corporate practice of medicine. And you also have the corporatization of medicine. So these are all major things that the practicing physician has to face. And on top of that, we have these two magical letters circling above called AI, or artificial intelligence. And personally, I think that's going to be probably the biggest shakeup in medicine. You know, being a researcher and a techie, I kind of see the potential of this. It can be an aspect that greatly helps with the care of patients, but if it's not limited and controlled and directed in the right way, the forces that are initiating artificial intelligence will eventually finish the takeover of medicine. I think, that'll be our worst scope of practice issue. It won't be the lower level practitioners. It will indeed be artificial intelligence.
You said that'll be the worst what?
Scope of practice issues. The doctors are worried about physicians' assistants, nurse practitioners, and so forth. But I think, competing against a computer, which has certain advantages to the computer, will be something that, that'll supplant a lot of the actions of the doctors.
Michael, when you say the computer, are you talking about AI?
Yes.
Yeah. Okay. Robots. AI.
Robots also, that's part of the advanced technology. During my presidency at the Pennsylvania Medical Society, my initiative was advanced technologies in medicine. And we spoke a lot about AI, going back about 5 or 6 years ago, and robotics. And it's also the initiation of certain sensors that will be applied directly by the patient, probably through your cell phone, which we're already seeing. They can take pictures of things and with data analysis and image analysis, do things that the doctor, in fact, cannot do. I could look at a lesion, but I can't measure it within millimeters to notice a change. I could look at a lesion with my eyes, but I can't look at it with a different spectrum of light, which gives me more and more information. And on the other side, the robotics are becoming more and more refined and not just an extension robotics like the Da Vinci system, but one where you can actually essentially present the patient before the robot, and the robot will do the surgery. Doesn't have to be an extension of your fingers or anything. I think one of the things I felt safe with in the past was doing ophthalmologic surgery. I thought our microsurgery might have been a bit too refined and so forth to be done by a robot. But lo and behold, there is a robot out there that's learning how to do cataract surgery. So, how do you compete against this in the future? And that's why I say it's a greatest scope of practice issue. The robots, don't show up late. They're, worry about the snow on the way in.
Yeah.
They don't take vacations
for
24 hours a day. Some of them even work in total darkness.
They don't eat. They don't sleep.
That's right. They don't go on strike.
They don't go on strike.
Wow.
They're typically a one-time payment. Michael, I have a question. When we talk about AI, it doesn't matter what sector it is in. There is a sense of anxiety and fear, and people think there's a loss. There's some kind of loss for me. What is it? They're going to come take my job. They're going to come do this, do that. What is the net negative for physicians? Then also, what is the net positive for physicians? Because there's some people who look at AI and think about robotics and they think, awesome, and they become inquisitive. But I would say most people are more concerned than excited when it comes to robotics and AI specifically.
That's true, Reid. And I think it's a basic fear. It's fear of the unknown.
Yeah.
If I'm going to come up to you and say, hey, look, I'm going to replace you by a machine. We're going to teach a machine that's going to do a lot of things better than you can do it. And after you devoted your whole life and hundreds of thousands of dollars and decades of education to be wiped out, it's a little more than replacing the buggy whip.
Yeah.
So it is a fear of the unknown, I think, is the greatest thing. And having done a lot of missionary work, there's some good aspects of that. We hope that a level of healthcare will get to those parts of the world that don't have any right now. And that would be pretty good. I think even, as I say, I don't see a real doctor shortage in this country. I think there may be a distribution problem, and that's based on economics. People don't want to go into a community that needs healthcare, but they can't make a living. And the government has to realize that fact and maybe make some sort of quid pro quo. We'll pay for your education, but you go there and help out people. We'll pay for your education, you go there and help out people, and we'll supplant your income so you can make a decent income. It's something fundamentally wrong with society. And I played a little semi-pro football, but I'm amazed that there's something wrong with society that I could throw a pass and have a good 3-point outside jump shot and make a hell of a lot more than I can saving a life. So these are issues that have to be based. And the good part of AI, I think one is data analysis. We're seeing that right now. So I come in with a new patient and I sit down and I talk, and I really enjoy my patients. Can't enjoy them too much anymore because see this one, move on to the next one. How you doing? How's your family? Where do you come from? What kind of work did you do? Okay, but if you look at AI, they could take your genetic profile, they can take your environmental exposure, every zip code you ever lived. They can take every medicine that you ever took and cross-reference all the reactions and interreactions. They can take your age and risk profile, okay, and interact all these parameters and do it in a couple milliseconds. I can't compete with that. I don't think anybody can. So that may be an advancement of medicine, but who controls that data and how does it go? So I could say, as they have in certain countries with healthcare, oh, we know you're 70 years old, you took these hundreds of medicines, you lived in these zip codes that had environmental exposure and high cancer risk, and we know exactly what to do with you. However, you're 70 years old. And our profile says it's just not worth investing you at this stage. We're not going to say you can't have the intervention. We're just going to say we won't pay for it. So what do you do at that point? So there are some basic issues with AI. And one of the problems I have with my colleagues is they're a little too passive. And one of the things I state with them, I said, look, you have a choice in your future. Are you going to have a seat at the table, or are you going to be on the menu? Okay, and this determines your interactivity, your advocacy.
Yeah.
And it's not just for us as a profession. I think this is a real ethical and moral issue for the care of people.
Right.
That's why we can't walk away from it.
Do you the same way? Go ahead, Neil.
We're like a bunch of sharks all going at the same time. Go ahead, Neil.
Are
That's
you
time
going to
for
be
all
on
of
the?
them, no
Are you
problem.
going to be on the menu? Or are you going to have a seat at the table?
Or
Or are you going to be on the menu?
Yeah, it's a punchline.
Yeah.
Yeah, that's good.
I think we should
Thank you.
adopt that. That's the DocNation slogan.
Yeah. We're
They
taking that.
might, they might steal that from you.
You're
Hey,
welcome to it.
Michael, I want to drill down on something you said earlier. You were drawing a correlation between medicine and your semi-pro days. You have 3 athletes on the screen, and we played high level sports, and we looked around at one point, and I've said this multiple times in our podcast, so you really struck a chord with me. And it's like we're looking around, we're getting paid to throw a ball, and more than physicians,
Right.
and it's just a really kind of a uniquely odd. And basically no other country do you see that. I mean, I know soccer is big all over the world, but you don't see that level of disparity. Can you talk a little bit more about that?
I think it's somehow what was presented to the populace. Like before we came on, I had the TV on, and they're talking about the Super Bowl, go Eagles, or whoever you root for.
Mm-hmm.
And people are paying $7,000 for a ticket.
Yeah.
And I grew up quite poor. My mother and father only went to the 4th grade. Okay. My father, at his best earning income annually, was $12,000.
What year was that?
When
Approximately.
Dad was at his highlights, I was probably going back and maybe to the 80s.
Wow.
80s.
Thank you for sharing that with
Yeah,
us.
mom was a saint. I know how she managed the family in that. And Dad worked like a dog. They were both pulled out of the 4th grade to go to work full time. And they actually had found out work before they went to school.
Mhm.
Dad was sent out to the farms in Vineland to pick tomatoes. And Mom used to go around the neighborhood with a little wagon to get clothing to clean and to repair for my grandmother and bring them back. At the 4th grade, they were pulled out to go to full-time employment. So it was really tough for them. I don't know how they made it. My dad worked his whole life and served the country very well in World War II. He never talked about it, but he was on the Normandy beach, followed up by the Battle of the Bulge.
Whoa.
How he survived and how I got here, I'll never know. But, that's part of it. So what brings people at that level today who are what we would call medium income to say, I'm going to come up with $2,000 to walk in the stadium and stand, or $7,000 to go to the Super Bowl. Okay. And when you go see your doctor, this same person will say, Doc, what could you do in this copay? I'm a little short. I don't have the $5 or $10.
Mm-hmm.
So I think there's a different value system. And I think that's part of the image. We don't really have star athletes anymore. We have demagogues. These people are at such a level.
That's right.
And you hear salary, you hear like Tom Brady. I think in my heyday, probably threw the ball as good as he did. But he just signed for $300-something million to be a TV commentator.
Yep.
You look at the guy at the West Coast, the Dodgers.
Shohei Ohtani.
Yeah, $700-something million. As a very successful physician, you will not make a fraction of that in your entire life. And these people are going to make more in a season than you made in your entire life. So what is it about society that has that value system? I think one of the things that I find depressing, I think, is the whole issue of the value of life has been deteriorated.
Mm.
And it has a lot of different aspects, such as war and stuff. And when it has a different entry into society, we kind of overlook some things, or we kind of have people justify it. Like, let me ask you a basic question. Do you think World War II was a bad idea? You're hesitating. The answer is yes, it was a very bad idea.
Yeah.
During the course of World War II,
What was the question? Do I think it was a bad idea? I think any war is a bad idea on anybody's behalf. Are you saying, was it a bad idea for the United States to retaliate
for
after we got
humanity in
attacked?
the United States, yeah, not the retaliation. The bad part about it is millions of people lost lives. The Americans lost approximately 410,000 lives during World War II, of which a little over 3,000 were civilian lives. May have been nurses, the Red Cross people, and so forth. Horrible figure, isn't it?
It's horrible.
Yeah. Well,
horrible.
guess what, gentlemen? Every year, the tobacco companies are responsible for at least that number of deaths in the United States, along with 1.2 million disabilities, chronic lung diseases, other cancers, and so forth. Same equivalent in
Yeah.
loss of lives, but I don't see us going after the tobacco companies or the social issue of smoking the
True.
same way that we look at World War II. And one of the reasons is a lot of people making a lot of money off of that.
Yeah, it's all about dollars. It's all about the economics.
Right. And a lot of people with that money knows what to do with the social aspect and advertisement.
That's right.
When you were growing up, your teenagers, you want to be a tough guy like that Marlboro man. If you're a young teenage girl, you want it to look like the young diva, when you smoke. So it's a certain amount of social attitude, I think, that has to change. And that's one of the bad things. I mean, I don't think we're going to be a totally pure society. We need a little variety, but let's not be harmful to that effect. So say you can wipe out 400,000 of deaths and another million of morbidity in the United States. How much money would that possibly save you? What is that human life worth that was cut 20, 30 years short, tethered to an oxygen hose? These are all valid questions, and they have a financial association too, but this is never brought to the issue.
I'm glad you bring this up, because this is where the politics comes into play, because how much leadership is being shared, even in like the school system. It used to be, back in JFK days, there was this school called the La Sierra High School. If you go look it up, you see elite warriors that are equipped, men and women, going through the program, and they had different colored shorts that they would wear that they would get different colors based on advancing, kind of like in martial arts, where you get different colored belts. And there was an emphasis on physical strength and taking care of yourself on a nutrition level, all these different factors. And it's like all that has gone away. And it's just like you said, society and culture is missing the mark on really valuing life and promoting attributes and virtues and things that are all about valuing life. And so I want to go back to what you said before about the AI piece. And we've traveled the world helping with teams do cataract surgery and see the blind get their sight restored. There was a 102-year-old man who got his sight. He was fully not able to see in both eyes, got his vision restored, and he sang a praise song in just complete emotional thanksgiving for having his vision restored. His 80-year-old son was walking him up the mountain. This is in Africa. And so we've been around the world in various places as a part of these teams. And one of the things that we've learned through ophthalmology is that you've got this struggle between who can do what, optometrists versus ophthalmologists. And I'm hearing you say that that's almost like the small potatoes. The big potatoes is this AI machine underway. And if 75% of doctors are now employed and the corporate medicine is taking over, and we're not at the table, you're on the menu and not at the table. Like, we have an opportunity here, I think, in this decade to do something for doctors to get back in charge of decision making, to be at that table. So tell us about that as far as what you've seen in some of these ophthalmologists, optometrists side of things. There's same thing with NPs getting more authority and having clout in healthcare. How are you seeing that as like a precursor to what's coming that's even bigger on the AI side?
Well, what I see personally, and I did a lot of missionary work, I do a lot of volunteer work with the veterans now. And they're, men that literally live and women that risk life and limb come back, in pieces disabled, and the mental aspect is crazy. And I don't think we're still taking care of them the way we should. But to get back to your question, bottom line is the use the word curing or treatment of disease. And personally, I don't care who does it. There is some legislation, but the bottom line, I think, that we all have to realize is you want the most capable education person at that point of taking care of people. Whether you say they're a medical doctor, a doctor of osteopathy, an optometrist, a physician's assistant, I think really at the end point matters, but maybe not to the degree that some of the political situations say that they can. We don't want to get into it, but I ran a tertiary eye emergency room in one of the academic hospitals. And we would see a lot of, I don't want to use the word mistakes, but a lot of things that came in at the end point when things went wrong and they already had treatment. That should be avoided. Okay. But if we have a robot that I could take with me in Project Orbis again and go down to the outback of Africa, where we actually had to bring our own energy system. There was no electricity there.
So did we. So did we.
And
Generators.
with teaching some technicians how to do the cataract surgery. There was one lady that was technically a quote unquote witch doctor. But, after doing a couple hundred cases under the proper instruction, she could do cataract surgery and do it adequately and deliver the level of care that was non-existent there. Hopefully, robotics will be able to supplant that, for all the reasons we just talked about.
Yeah.
But the bottom line is somebody owns that robot. Somebody developed that robot, and somebody wants some sort of remuneration for those efforts. Even beyond that, they may want control of that. So the robot may be nice, may be sophisticated, but may be going to the highest bidder. We've seen that with laser surgery. It wasn't available anywhere. And it became available, and they went right away to where the best marketplace was. And I don't want to see healthcare to be a matter of marketplace. I want to be seen as a matter of elevating the extension and the quality of life. If we could focus on that, I think then we know what the real note is in the symphony of taking care of people. So I'm hoping that the directive will be more in that direction, Justin, to answer your question. Will it be? I don't know. We've seen what happened in the past marketplaces, hopefully it will work that way.
Michael, what can physicians do to be have a seat at the table and not be on the menu in terms of AI and their contribution to AI?
I think one of the things they have to do is get involved, get up off the seat, the seat that you're on now, not at the table, and be aware and have your experience, even if you're not a techie. You look at the older pre-med guys, they were Latin major, they were botany majors, and so forth, and that's what went into med school. Being on some med school committees, I used to say to the committee, give me scientists, give me engineers, give me people that are in the humanities too. But I think we've got to look at it, the deployment and the advancement of medicine. And that, for the most part, is going to be made by doctors who work with the scientists. I think if you look back at the advancements of medicines, catheters, radiology, microscopy, they were all from the outside sources, scientists that were brought in and that were adapted to focus on medicine. So I think, Reid, that's what we need, the doctors to work as a group. If you say, oh, I'm old, I'm not a techie, you have a lot of experience. You know what the problems are.
Need your
And you
help.
know what the solutions are. You may not have the modality, but some scientists somewhere may work with that. That's great. I mean, I can't imagine doing brain surgery 80 years ago before, 100 years ago with Röntgen without radiology or MRI. Where are you going about in the skull? It's almost Frankenstein-like.
Yeah.
When you look at the things today, and when you look at some of the advancements today, and talk to a physician of only like 30 years ago, it's not science, it's almost magical. But let's proceed in that direction. I mean, and you don't know where the answer is going to lie, gentlemen. I mean, if I went up to you and say, hey, you know what? Give me $1 million. I want to study moldy bread. And you say, what? Bread's moldy. Throw it the hell out. It only costs you $1 to get a new loaf. And then in the course of studying moldy bread, I developed these things called antibiotics. I saved millions of lives. I saved millions of people of a lot of devastating residuals from those infections. So we don't know where the true answers are going to lie, but we know what the true questions are, and we hope we can direct our efforts to providing those answers. And I think with AI, with robotics, with the advancement of medicine in general, we can establish a quantum leap, which we never had before. Along with the education of medicine, one of the things I think about is that, the residents I teach routinely tell me that they're $400,000, $500,000 in debt. And, if you talk to somebody like my father, who never made that his entire life, that's a lot of money, and it still is a lot of money now. But what can we do with AI and the media, just on the education? I know going from physics and math into med school, I was horrified. I said, this isn't learning. I'm sitting on my butt trying to stay awake for 8 hours in class, and I'm going home and I had volumes of things just to memorize and to spit back during a test.
Yep.
So suppose we step back. Suppose we made those 2 years of medical school all on the internet. You can take it and analyze it any time of day that you want. You can go back. If you're studying the foot and you got a question about the big toe, there's all these links to answer those questions, and then have a good in-depth testing. So look at the expense that you do away with on the education of the individual, but also look at the quality of education that you're bringing up. A lot of people can have access to that, and that's really not all that innovative. You have all these online universities, quote unquote, and I have to admit, in the beginning, I really had my doubts about them, and they were questionable. But now you have graduate courses at, renowned institutions. I mean, I'm a bachelor, I'm home alone at night. I get bored with TV. But if you go on YouTube, Stanford has a YouTube channel. Harvard has a YouTube channel. Johns Hopkins, Caltech. I took most of the graduate courses in optics, didn't pay a penny. They were available in MIT. It took me a few years to get through them, but I would never have the opportunity to learn that and advance my field if that wasn't accessible to me. At this stage of my education with, 2 doctorate degrees and 3 residencies, do I need another certificate on the wall that's going to cost me $100,000 to get it? I don't think so, and I won't be doing it. I need the knowledge.
Yep.
And that opportunity gave it to me. And hopefully I can apply that knowledge, advance the field, and have for me, a much more satisfying position in life.
I appreciate your focus on the value of human life. I feel like that's been a theme throughout everything you've shared with us. And specifically with the AI, like if AI is programmed a certain way to make decisions, how is it going to decide, and who's deciding what it should be thinking or how it should be approaching things? And patients need access to care. And you mentioned it doesn't really matter at the end of the day if they're getting the care that they should be getting, and it's good care. It's not care coming in with mistakes and issues and things that, it's a team approach. And so I appreciate your perspective on that. That's very much patient oriented. It fits so well with what you've done up to now, all these years. And we appreciate you being on the show with us and look forward to continuing the conversation.
Be happy to, and I really have to admire you for your effort at DocNation to have the media that you have, and really fulfilling a need that wasn't fulfilled before. I think the doctors should work with you. We should all go forward, and I think it'll be better for humanity. And that's the bottom line.
Thank you, Michael. Appreciate your time.
Gentlemen, thank you very much. You have a good day. I look forward to working with you in the future.
This has been the DocNation Podcast. If you like what you heard, be sure to subscribe, rate, and leave us a review on Apple Podcasts, Spotify, or wherever you are listening to us. Your feedback really helps us reach more listeners like you. We'd also love to hear your thoughts and any topics you'd like us to cover in future episodes. Don't forget to follow us on Facebook, Instagram, and LinkedIn for updates, behind-the-scenes content, and to join the conversation. Thanks for listening.